Hey everybody. Today we're going to talk about drugs affecting the GI system. This is a pretty straightforward, easy chapter because we're lucky that all of the medications that are listed here that we're going to talk about, almost every category, the medications in that class are equally effective. So for the most part, it is that when you decide which medication to prescribe, you're going to just pick one. There may be one that's cheaper than another, but there's not a whole lot of difference in these. So what we'll more focus on is when do you pick one over the other. So for when do you pick an antacid versus an H2 antagonist versus a proton pump inhibitor. So first we're going to start off with GERD treatment, gastroesophageal reflux disease. This is just an algorithm for it. So if you have typical GERD symptoms, you want to first try on the right-hand side of the screen lifestyle modifications and an antacid or an H2 antagonist or an H2 blocker as needed. If you haven't had any relief in 2 weeks, then you want to continue those lifestyle modifications. You may have to schedule an antacid or an H2 blocker, and then if still don't have any relief, then you will probably start a proton pump inhibitor to titrate at the lowest effective dose. Use it for usually 8 weeks, and then try to discontinue therapy over a slow taper to prevent rebound GERD symptoms. Antacids are going to be your easiest medication for GERD. So it's just a medication that neutralizes acid in the stomach. These are things like Tums that you see over the counter. They're chalky. They're just made up of aluminum, calcium, or magnesium, and they just decrease the pH of the stomach quickly. Different formulations have different side effects. There's not one that's more effective, but they're all not absorbed very well. But your calcium-based antacids are contraindicated if patients have hypercalcemia. That makes sense. Magnesium and aluminum should be avoided in renal failure. But other than that, they're pretty benign. They start working within 15 to 30 minutes. They work for about an hour to 2 hours, and then the effect is gone. So they're really great for patients who know that a certain medication gives them heartburn. If I know that pizza or red tomato sauce, because it's acidic, it gives me heartburn, I can take one of these 30 minutes before my meal, eat, and then I don't have those heartburn symptoms anymore. Not great. They're not great for patients who require routine medication or who don't know what their trigger is, except for treatment. But they're not very good for prophylaxis or routine prophylaxis. Adverse drug reactions. Magnesium-based antacids can cause diarrhea. That's a risk with increased use. If somebody's having to take antacids 3 or 4 times a day, they have a risk of having diarrhea. And the aluminum and calcium-based antacids can cause constipation. The only drug interactions antacids are going to have is they may affect the absorption of most drugs. Usually you can separate the administration out by 2 hours and avoid any of these interactions. One to remember is fluoroquinolone antibiotics. They become chelated by the antacid. So what happens is the aluminum, magnesium, or calcium binds to the fluoroquinolone, and then it can't be absorbed in the stomach. So you separate them out by at least 2 hours, and you can have proper absorption then. So you don't have to stop therapy or change the antibiotic if you don't want to. You can actually just separate the administration out. Here's a slide on rational drug selection. Basically, it's honestly going to come down to cost. These are fairly cheap. They're over the counter. Very easy to get their hands on. You just want to make sure that if a patient's getting them over the counter, they're not overusing them, that they're using them appropriately, and if they're having to reuse them routinely, to let you know so that you can prescribe something that is a little more long-lasting effect. On this slide, it's important to let your patient know that if they're using them for longer than 2 weeks, they need to contact their prescriber. They need to know the symptoms of a GI bleed. So if they have that dark black tarry stool, or if they're having sharp GI pain, they need to contact somebody immediately. And they need to be aware of lifestyle changes, because that's the only thing that's going to change long term. They need to avoid spicy foods, stop smoking. They can elevate their head while sleeping. Those kind of things are going to be more long lasting changes than just taking an antacid every time they have heartburn. H2 blockers are competitive blockers of histamine in the stomach. So it's going to block the secretion of gastric acid. You can see here our options: ranitidine, cimetidine, famotidine. Those are our three most common. It says here that some are more potent than others. That really is they take that into account when making the dose. So even though it's more potent, it's not really more effective. So you can recommend any of these. One thing to note, cimetidine, I never recommend cimetidine for patients because it has a large number of drug interactions, and it has worse side effects than the other two medications. The most commonly used one is Zantac. It's available by prescription and over the counter. So it's fairly cheap no matter where they get it, with few drug interactions and very few side effects. Adverse drug reactions. It says here gynecomastia and impotence. I've never actually seen that with these. It's very rare. Cimetidine is the worst for this, and it's dose dependent. Most people who take Zantac and who take or Pepcid don't report any adverse drug reactions. So when you give an H2 blocker, you're going to take it with meals, because again, it's going to block the acid secretion that happens when a patient eats. So they eat, the stomach produces acid to dissolve the food. So you're going to block some of that secretion to lessen their symptoms. So you want to make sure they take it with a meal, and you want to separate it from antacids by 30 minutes to an hour, just so you get the most effect if you are giving them together. Here's a chart of equivalent doses. So if you have a patient who comes in who's on cimetidine or who's on famotidine and you want to switch them to ranitidine, here's the equivalent dose based on efficacy. Proton pump inhibitors are very highly used nowadays for GERD and for heartburn. What they do is basically you take them before you eat. The drug goes and it blocks the acid secretion through the pumps in the stomach, and the decrease in secretion can last up to 72 hours. So you have to take it before you eat, because that pump has to be activated to want to produce the acid, and then the PPI essentially blocks that pump so that none of the acid can actually get out. Commonly used for GERD and other things: H. pylori infections, peptic ulcer disease, Zollinger-Ellison syndrome. Commonly used for any or any disorder that has increase in acid secretion. Proton pump inhibitors can be used in pregnancy. with caution. Congenital abnormalities have been reported, but in general they're category B or C, and they can be used with children. The biggest ADRs for proton pump inhibitors are reduced in nutrient deficiencies, so iron, B12, and calcium. Long-term use of PPIs gives an increased risk of this. A normal 8-week regimen is not going to cause deficiencies in those. This is more for patients who have continued use longer than 8 weeks. Long-term use of PPIs also has an increased risk of C. diff infections or opportunistic infections of the GI tract, and there's a questionable cancer risk that goes along with the PPIs. You'll see more and more publications coming out about problems with long-term PPI use. So in general, you want to keep the regimen as short as possible. Try for an 8-week regimen if it's treatment for GERD. You may have to do long-term maintenance therapy. It's not contraindicated. It is something you can do, but you want to keep it as short as possible. And then when you stop it, you want to make sure you taper the patient down, because when you stop this PPI, there's going to be a rebound in acid secretion. So they've been used to this more basic stomach environment. Even though they're going back to their normal acid secretion, it's going to be an increase, so they're going to have some heartburn symptoms. So if you have a patient taking a PPI BID, you may want to do daily for several weeks and then stop it. If they're taking it daily, you might want to cut it to every other day while you're tapering it, because you're still going to have an effect of the PPI for several days after each administration. So you want to make sure you taper it down as slow as the patient needs. Of note for drug interactions, can decrease the effectiveness of atazanavir, idinavir, and nalfenavir. Those are HIV medications. It can interfere with drugs that require an acidic environment to be absorbed. And a big one you'll see is omeprazole and clopidogrel or Plavix. There's a black box warning for that interaction, increasing the metabolism of Plavix and making it less effective. So if you have to give a PPI and Plavix together, you just want to pick a PPI other than omeprazole. Here's another chart of equivalent doses for patients. If you were going to have to switch them to something else, you would know what an equal dose would be. So that's heartburn in a nutshell. It's very quick. There's 3 categories to talk about. They're all equally effective. There's just small changes in between each medication. So we're going to jump into antidiarrheals. Causes of diarrhea can be infectious, food or drug induced, or some type of inflammatory bowel disease. You want to first try to figure out what the cause is and stop that first. If you can't find a cause, or you need something to work while you are treating the cause, then you'd want to go to an antidiarrheal. So antidiarrheals can be absorbent preparations, so you can have bismuth subsalicylate. That's just Pepto-Bismol. You can have opiates, which are Imodium, which is over the counter. Yes, Imodium is an opiate, but it's such a low potency that you have to take way more than any human being is going to take to get any type of euphoria or pain relief. So it is safe to take over the counter. Then your prescription-only products are Lomotil, which you see a lot more often than Metofen. I've never actually dispensed Metofen, but we do use Lomotil for patients who, if Imodium is not effective, we will switch them to Lomotil. Lomotil is a controlled substance, so it does have restrictions on prescribing where you can only prescribe, a prescription's only good for 180 days. So here's a small chart, or a quick chart to just compare your options. These are the three most common options: Imodium, Lomotil, and Pepto-Bismol. It goes through their indications, what the doses are, and then common side effects. For the most part, you can see those side effects are minimal. Obviously, abdominal pain and constipation makes sense since we're stopping somebody up. The one I want to point out is Pepto-Bismol, that black stool and tongue discoloration. That can be very frightening if a patient doesn't know that's going to happen, because when they're taught with a black stool, that could be a sign of a stomach bleed. So you want to let them know that it is the Pepto-Bismol. If their stool becomes a dark color, that's fine, as long as they're not having any other symptoms of a stomach bleed. So again, in acute diarrhea, you want to treat the source first. You may want to use an absorbent or an antidiarrheal with each loose stool, and then you want to make sure the patient maintains hydration. So electrolyte solutions for kids, Pedialyte or something like that, and then water in adults, or maybe diluted Gatorade. So this is a medication that we don't see very often. It's an antidiarrheal approved for patients with HIV or AIDS who are taking antiretrovirals. It requires twice a day administration without regard to food. I believe that's because there's so many drug interactions with antiretrovirals. Any pause in therapy or decrease in efficacy can lead to resistance to their antiretrovirals. So this would be a safe medication you could prescribe the patient. Cytoprotective agents. This is a real quick class of medications. Basically, these are medications that bind to the stomach tissue and protect the stomach, and basically act as a barrier for patients for developing like an ulcer. So NSAIDs are a common cause of ulcer formation, especially long term. So you can give medications like Carafate or Cytotec. Carafate does nothing. So just so you know, Carafate does nothing for the pH of the stomach. It doesn't actually decrease the pH or help with the side effects or the symptoms of GERD. But what it does is it binds to the ulcer tissue and acts as a barrier to the stomach. So it's just providing another layer of protection to that tissue. Cytotec, usually it inhibits the gastric secretion and has mucosal protective qualities. And it's usually only given to patients who have had a previous ulcer or are currently have an ulcer. Something to keep in mind is Cytotec or misoprostol is a pregnancy category X. You cannot give it to a patient who's pregnant, and you want to make sure the patient is pregnant before you prescribe this medication. Carafate or Sucralfate, the only side effect is constipation if taken at high doses. Other than that, it's very, very tolerable. Antiemetics, these are medications given for nausea and vomiting. There's a couple in this class. Really, we've gotten to the point now where we really only use the 5-HT3 antagonist unless there's some other reason to have to use a different class of medication. So we have antihistamines that are effective. We have phenothiazines, which are actually antipsychotic medications, but given at low doses, they're very good at nausea and vomiting, and that's actually how antipsychotics were developed or were discovered, as they were developing nausea medications for surgery, and actually found that they decreased their psychotic symptoms. There are cannabinoids that you can prescribe, and then 5-HT3 antagonist blocks serotonin, and those are ones you're probably very familiar with, like Zofran, that come in tablets and orally disintegrating tablets that can be given to patients. So the antihistamines, of course, side effects are going to be drowsiness and then anticholinergic side effects. Your phenothiazines usually only cause drowsiness. EPS, extrapyramidal side effects, are possible, but at the low doses we're giving of these medications, they're not very common. They're really not common with those. Your cannabinoids or dronabinol, that is really only given to cancer patients who are we're trying to for nausea and vomiting. Can have some euphoria and mental status change, and seizures and seizure-like activity has been reported. This one is a controlled substance also, so it requires or it has restrictions on the prescription, and it's kind of hard to find in a pharmacy just because it's not used that often. They don't usually keep it in stock. So you may want to let your patient know, if they're going to be prescribing it, to go ahead and ask their pharmacy if they'd order it for them. Your 5-HT3 receptor antagonist, fairly well tolerated. Constipation, headache, fatigue, dizziness, and diarrhea that's listed there, really very close to placebo. They're actually very well tolerated, except maybe a little bit of fatigue. So in clinical use, nausea and vomiting due to drugs or really any cause, you're going to give 5-HT3 receptor antagonist. Then you may fall back to a phenothiazine for adults. And dronabinol, like I said, is only for chemotherapy-associated nausea and vomiting, and then appetite stimulation. For motion sickness, you're going to give antihistamines, so meclizine or diphenhydramate. Those are over-the-counter medications that they can get. They can buy without a prescription, and both fairly inexpensive. So that's antiemetics in a nutshell. Prokinetics, these are medications we use to stimulate the motility of the GI tract without stimulating gastric, biliary, or pancreatic secretions. Metoclopramide is the only medication in this class. It stimulates motility in the upper GI tract, so that but it doesn't stimulate motility in the lower GI tract. Got a black box warning for tardive dyskinesia, which is an extrapyramidal side effect. It is rare, but it can happen at high doses and long-term therapy. ADRs, any of these are possible, but the ones that you're really probably going to see the most are diarrhea, dizziness, and then with long-term treatment, maybe some depression, but it's not common. So laxatives, there are 6 classes of laxatives: stimulant, osmotic, bulk-producing, lubricants, surfactants, and hyperosmolar. Stimulants are just what it sounds like. They push they cause the GI tract to push and to stimulate motility. Osmotics are good for putting. They pull fluid into the GI tract to help stimulate or to help the bowel movement. They're not as abrupt as the stimulant laxatives. Bulk producing laxatives are also known as fiber laxatives. So really, they're just good for keeping you at a normal rhythm or keeping you regular. Lubricants, mineral oil. That one can kind of be rough for patients, so it's not used very often. Surfactants or docusate compounds. That is a stool softener. So it doesn't actually do anything to help push the bowel movement, but it makes it easier to push. It makes it it puts more fluid into it, so the stool's not as hard. And then hyperosmolar glycerin and lactulose, they are good to take for patients who need a little bit of both, who need some stool softening but also need some stimulation. For all of these, you want to watch a patient's bowel activity. You don't want to push them too far one way or the other. You want to make sure that you want to make sure that that a patient's GI tract is there's nothing else going on. That there's normal activity. There's no blockages. Let them know that they're going to have some cramping or flatulence, but if it becomes unbearable, it'll let you know. So clinical use depends on the class of the drug. If you need a rapid response and short-term use, a stimulant might be the way to go. If you need an osmotic laxative is good for patients who need a little bit more long-term use. Polyethylene glycol or Miralax, it can be taken daily for patients who have constipation issues. And surfactants or docusate can help within a few days and then can be continued for a longer term if you need to. Here's a chart of medications that may cause constipation. So you would want to stop these medications or change them if possible before you started a patient on another medication. You don't want to treat a side effect of a medication with another medication unless you just absolutely have to. Now we're going to talk quickly about vancomycin. This is included in your GI chapters because of one of its uses. The main use for vancomycin is actually not for GI infections. It's going to be for methicillin-resistant Staph aureus or complicated infections, but it can be used for treatment of Clostridium difficile. So because it has poor oral absorption, vancomycin is actually just too big to pass through the stomach. You can't give it IV. You have to you give it PO, and it's not absorbed. So it goes through the GI system, kills the C. diff, and then comes out in the stool. Because of that, you don't have the same side effects. So you can see here under adverse drug reactions, it causes ototoxicity and nephrotoxicity, which is why you have to check the trough levels for vancomycin. Those don't happen when you give it PO. That's only IV. It also causes red man syndrome if it's infused too fast. It looks like an allergic reaction, but it's not. It's just a histamine reaction to the drug being infused too fast. So you can give the infusion slower, or you can pre-treat with diphenhydramine, but it's not an anaphylactic reaction. Clinical uses for serious gram-positive infections that are resistant to other medications, and for Clostridium difficile. When you monitor, you have to check vancomycin troughs to make sure the levels aren't too high. If they're too high, you're running the risk of nephrotoxicity and ototoxicity, and those can be permanent. When vancomycin is given PO, you can actually get that as a prescription at the pharmacy, or hospital pharmacies will actually make an oral solution based off of the IV formulation. So you don't have to treat a patient inpatient with this. You can give them a prescription, but it can also be used in the hospital. Difficid is another antibiotic, a newer one that's used for treatment of C. diff. It's administered twice a day. It's not well absorbed. The studies have had it moved up in the guidelines. It's actually first-line treatment with oral vancomycin. It used to be that metronidazole and vancomycin were first and Difficid was second based on price. But now Difficid has been shown to resolve the infection a few days sooner than metronidazole, and metronidazole is growing in resistance for C. diff, so it's actually become Difficid and vancomycin are actually first line in the guidelines, which is contradictory to what your book says. Here's a chart of antibiotics that are known to cause C. diff. We always hear clindamycin is the cause of C. diff. Usually that's one of the medications they've been on, but it's not the leading cause. Any of these can be the cause of C. diff. On the left-hand side, usually clindamycin is the last drug the patient's been on, because they'll have been on, say, a penicillin, then a fluoroquinolone, then clindamycin, and that's when they're diagnosed with C. diff, because you've killed all the good bacteria in the stomach, and Clostridium difficile has taken that opportunity to infect the patient. So that's GI drugs in a nutshell. There's more C. diff guidelines on Canvas. I can give you more information about these medications and their classes, but it's pretty straightforward. So if you have any questions, just shoot me an email.